Okay, let's see if we can get through the rest of this. So part two. Okay, we talked about Osgood-Schlatters. Now this is an ACL tear. So when a patient has an ACL tear, they're going to come in for an X-ray because they've had an injury and they're like, "Oh my gosh, my leg hurts so bad." It could be a lateral meniscus tear as well. Same concept. But the first line of X-ray imaging or imaging in general is going to be X-ray because they're going to want to look and see if there's anything bony that is fractured. Once they see that there's nothing bony fractured, then they kind of know that it's an ACL or a medial or lateral meniscus tear, and they will send them in for an MRI. But nonetheless, it's always X-ray where they get started. So this is caused by, this kind of tear is caused by when you change directions rapidly. So again, we're talking, obviously, the reoccurring theme here with these injuries is aggressive sports, soccer, football, anything where they're stopping and running, especially if you have cleats and your cleats are in the ground and then you jerk to move to another direction. You're changing directions quickly with your foot still basically in the ground, so it can cause a problem. This causes a lot of pain and swelling. They're not able to use a full range of motion. It hurts to walk, as you can imagine, just by looking at this drawing right here. This is the ACL. So the anterior cruciate ligament is the one that's anterior, okay? So I'll get that. This is your anterior cruciate ligament, and then what crosses behind it on the posterior side is the posterior cruciate ligament. So that's the PCL. So we have ACL and PCL, okay? All right, so an avulsion fracture, osseous fragment caused by an ACL tear, okay? So this is a patient that had a tear of the ACL, but it also pulled a piece of the, probably it looks to me like without seeing the AP, it pulled away a piece of the eminence, the intercondylar eminence of the tibia. And so that is a tear and avulsion fracture right here. So that is one of the eminences turned on its side, and that's the one that's up straight. So this is caused by the ACL pulling that away. So that's kind of what they're looking for when they do the X-ray, and by seeing that type of fracture, they know automatically that it was the ACL that tore that. So the knee anatomy, you don't usually, it's funny, everything else I really will never bother you to know tendons as much. I mean, obviously the Achilles tendon is very important in terms of, fractures and things that occur in the distal tib fib and the ankle and the foot. But the one other that I would say that you really need to know are your tendons down here on the knee. So we have a patellar ligament that goes all the way around here and attaches to the quadricep. Okay, so that is a ligament because it is the ligament, the reason it's called a ligament here is because from here to here, it is attached, it's linking bone to bone. And then, so here's the patellar ligament, and I think I called it the tendon earlier, but patellar ligament, and then the patellar tendon, because here it attaches bone to quadricep muscle. So we've got patellar tendon here and patellar ligament down here. So the patellar ligament attaches to the patella and then attaches to the eminence on the tibia, which anyone can feel. You put your finger down on your tibia, you can feel that prominence there on your tibia. Here's an anterior view of it. All right, so fracture patella, this is, we talked about the sesamoid, the bipartite sesamoid and all that kind of stuff. And as you can tell, this looks drastically different. We've got, we don't have smooth edges. We've got pieces of the bone. We've got one bone here, one here. There's a fracture here. There's a fracture here. And so that is a shattered patella bone. Only 1% of broken bones are in patellas. It's very rare. And typically it's caused by a direct blow to the knee, such as a bad fall or a motor vehicle crash where the patella hits the dash, or at worst, I hate to think of it this way, but you hear about, in movies, violent movies and stuff, they're like, we're going to take a bat to your knee and, bust your kneecaps. And so something like a bat hitting a knee really hard like that intentionally would cause a patella to fracture. And this is what it's going to look like on an AP. You're going to see, the fracture line there. And then, of course, on a sunrise, you're going to see it like that. It's a beautiful sunrise. So prepatellar bursitis is when the patient has the bursa is the area that holds it's a jelly-like sac that holds a cushion type gel type fluid in it that prevents things from hitting the knee directly. It gives a cushion there. So that's normal for it to be there. Normally looks like this. But when it becomes bursitis, it swells up and there's a lot of fluid in front of the patella like that. So when you see a patient like this, they have bursitis, and this is what it looks like on the x-ray. Common for people that are constantly kneeling or using their knees a lot for their work. People that lay carpet, they have to use that little machine where they constantly hit it with their knee. Something like that's going to, continuous repetitive motion like that's going to cause that problem. Common pathology of the hip and pelvis. Osteoarthritis is always the top cause. And so here we have osteoarthritis that's caused the degenerative joint space there of the head of the femur and the pelvis at our acetabulum. Here's what it looks like when it's normal, and you can see the difference, with osteoarthritis. Hip dysplasia is when basically a hip is not aligned where it's supposed to be in the area where the acetabulum is going to be, and this is detected at birth. And the way that they detect this, they call it the Galazzi sign, and they now test this at birth. I had this as a baby, but back then they didn't really do this. But now, as soon as a baby's born, they put their knees up like this, and they look to see if one is higher than the other. And if it's higher than the other, that's called the Galazzi sign. And they know that they've got to put the baby in a little brace. And the infants now are put in a little brace like this. They usually only have to wear it about 4 to 8 weeks. And it's horrible. Parents hate it. They freak out. But if they do this at birth and get that situated, then the patient's, gonna, grow correctly developmentally. Their acetabulum and their femoral head are gonna be in place, and they won't have a problem with that. But this is what it looks like on the x-ray. So a hip fracture, we've all seen them by now. Hopefully you've seen, not hopefully, but you know what I mean. Hopefully you've been able to identify this. If a patient comes in on a stretcher and their leg that's injured is rotated out to a 90 degrees like that, we automatically know that we have a fractured hip, and we are not going to in any way, shape, or form rotate their hip in. You can go ahead and rotate in the good hip. But honestly, what's the point on an AP pelvis? But I think the protocol typically is to go ahead and rotate in the good hip. But you're going to leave this one alone on the AP pelvis. Intertrochanteric fracture. So we have our femoral neck fracture, which is the most common proximal hip fracture, but also between the greater and the lesser trochanter. That is called the intertrochanteric fracture, and this is the subtrochanteric fracture below the intertrochanteric. So what happens when the intertrochanteric is fractured, if it's a complete fractured, it's going to cause a complete displacement of the femoral shaft from the femoral neck. So here is our femoral shaft. It's kind of going like this. It's sticking out of the hip up here. Sometimes it even can cause an open fracture. A compound fracture. But we're seeing the neck right here, and this is the head right here. So that's when the intertrochanteric fracture is really bad. It's going to displace the shaft from the femoral neck and head. Femoral neck fracture is going to look like this, and it's going to be above the trochanter. So again, here's our intertrochanteric. That looks fine. And so this one is just a complete fracture of the femoral neck. Hardware, you're going to see all different kinds of hardware, and that is just based on the severity of the femoral fracture or the proximal femur fracture and if it's displaced or not. So this is considered a complete prosthetic because they've put a rod down here into the femur, but they have completely replaced the femoral head with a piece of hardware. Don't get me started on what specifically that's called. Here, if the fracture is going through the trochanter right here and it is not displaced, okay, so this one you can see this one, here's the intertrochanteric fracture, but it's not actually displaced, then they're going to use a nail that looks like this, and it anchors into the femoral shaft. And so they're going to try to get that patient by without a complete hip replacement. So a lot of that again is dependent on age. If this was probably a patient that was, 50 years old, then they're going to try to do something like this instead of a complete hip replacement if the femoral head was intact. And then again, here's just the nails. So this one, the fracture was, it looks like just in the head, and they did the, did the screws or nails, whatever they call them. So it just kind of depends on how bad the fracture is, the patient's age, the patient's condition. All right, that's it on part 2.